always helpful from somebody from The Ohio State University to introduce somebody from The Ohio State University. Thank you. I don't remember, is this just move forward here? Yeah, that's forward. Great. So Dr. Narula asked me to talk about bariatric patients, lots of trained staff, consistent teams. Does this affect safety and outcomes? And my disclosures, I do get some honorarium from Covidian and fellowship from Gore. So the other disclosure in talking about OR teams is I'm in the OR on Mondays. And I am very cranky in the morning on Mondays. And they have a nickname for me when I walk in the room if I'm in a good mood or a bad mood. So I will admit that that is part of this consistent OR teams. But just bariatric practice, I mean, bariatric, it's a unique operation. I mean, it's in our institution too, it's the most commonly performed elective general surgical procedure. So it's not just boutique-y kind of procedure that's being done sometimes, but it's very common. It seems like somewhere in the US between 170 and 250,000 operations are being performed per year. It's not just a gastric bypass program anymore or a band program, but most programs do have a procedure preference, but usually it's a gastric bypass or a sleeve or band or a switch. These are the operations that are being performed. And most institutions do have a little bit of a preference. We do all of those except for the switch, so the common operations that were performed. And typically we're pretty uptight. We have a pretty stepwise approach to how we do these operations. Every operation tries to be exactly the same, which does lend itself to have a team that really understands what those steps are. The other argument, I think, for a consistent team is that these are pretty high acuity cases. From everyone in the room, there are some unique circumstances with bariatric patients. It's high acuity. There's airway issues, there's IV access issues, there's fluid management issues, monitoring. Do you have blood pressure cuffs versus that can actually fit the patient in a recording accurately? Do you need A-lines, et cetera? And surgeon preference and anesthesia plays a big role in that too. Plus, there's lots of different comorbidities that does affect anesthesia, sleep apnea, diabetes, high blood pressure, and amongst a million others, but these seem to be the most common that we have to deal with as well. In surgery, not always straightforward operations. Obviously, obesity is a problem. Body habitus, thick abdominal wall, large livers, intra-abdominal fat, short mesentery all make this a little bit more of a stressful operation and frankly, physically exhausting sometimes operations for surgeons as well. Insufflation pressures and going up and down on that can cause organ dysfunction and understanding that as well. And the more difficult technical operations that we have not necessarily lead to more complications, but have me as a surgeon worrying about making sure that the operation goes well, because I'm probably the only one in the room that really understands what those complications mean for the patient and us long term, so really want to make sure that operation goes well. And the OR staff has some concerns as well that may be unique: positioning, securing, transferring that patient from the OR bed to their hospital bed, et cetera, knowing what size, the beds, how much weight it holds, et cetera. Not everybody in the OR knows all the weight requirements, but the bariatric staff certainly does, and what's too big, and when you can do split leg, and when you can, backwards or forward, and how to use that table, where the extra long instrumentation is in the hospital somewhere, wherever central supply is in our hospital, it's there somewhere, and nobody seems to know where those are sometimes. But Foley catheter placement, not always easy in these obese patients either. And then we have protocols. I mean, everything's protocolized, I'm sure, in your institution too. We have sleep apnea protocols, pain management protocols, insulin drip protocols for patients' glucoses or whatever. And we pretty standardize that among the surgeons, but not always, the team has to know what those are as well. And since this title is called What Bugs Me, this is my What Bugs Me slide. Just to, when I see someone unfamiliar in the OR, that is immediately, I get this stress response. I mean, I'm sure you all do. I know that they don't know the operation that I'm going to be doing, meaning they don't know the steps of the procedure. And more importantly for me is they don't even know when we've strayed from the usual steps. Sometimes if someone has a previous Nissen or giant hiatal hernia, sometimes I'll do that part of the operation first versus the small bowel. But then when I ask, we need the first staple load, they're giving me the beginning and the small bowel part and don't even recognize that we're not doing that. We do have a cheat sheet in the kit that tells me all the steps that we do, but they don't even realize that we're not on those steps, and that's stressful for me too. And also when there's a problem and this didn't go right, wow, that EEA staple line fell apart completely. They're still ready for that next step and don't recognize that there's a problem. So that's the people that, then it can get even worse. It can be people that don't know the equipment. I've never used an endo stitch before. I've never used the iDrive before. I've never used an EEA stapler before. I've never loaded buttress material onto that before. I've had people hand me it with the buttress material on the outside of the stapler to fire it. Pretty just, you know, if it was sterile, I'd bang my head against something. But you know, that makes it a little more difficult as well. And then also, I mean, they don't know me either, and that's the next step, I think, in this and how little they know you. Meaning that I tend to be pretty quiet in the OR. I don't talk very much. That's just because the people who know me know that's just the way I am. People that know me think it's because I'm angry or mad, and they're intimidated by this, and they also don't know what I like. If I get some bleeding, the scrub techs I usually work with will know exactly what hemostatic agents I like, or that they'll go to a clip first, or go to an endoloop next to it. So they have that already, where the people don't even know what even to ask for or what to get. And then really that next one is that I don't even seem to care that they don't know what they're doing, and that bothers me on some level that I probably have never really verbalized until I had to think about it for this talk. That I want them to at least care that the operation is going well. And it's always that one that starts as, I haven't worked with you in a really long time, I don't really know how to do this, please don't be mad at me. At least I feel like, okay, you care. But anyway, the argument for a consistent team. And I think that unfamiliar staff really makes me, even though it's hard to find data, when I looked at this, it really requires me to focus on more than just doing the operation, that I'm not staring at the monitor anymore, but I'm worrying about them at the back table. I'm worrying about, I need to sometimes go back there and load the endo stitch or unload the endo stitch or get the stapler on or check the buttress or make sure that they've set up the EEA that I've liked it, that the knot is not going to fall apart on the inside, as I've done that so times. It just takes me away from the operation. I do work with residents and fellows. My job is really to make sure that they don't screw it up, that they're following the steps. So my eyes never leave the monitor to make sure they're running the bowel the right way. It hasn't flipped around. And when I don't have a team in me that I have to go back and look at the back table, I take my eyes off it, and it stresses me out as well. And that can lead to temper flares, and that OR environment, which is so important, I think, can change pretty quickly. And that stress leads to mistakes, and then you forget things like asking anesthesia to take the NG tube out. And because no one else in the room is really familiar with the operation that it has to come out, you forget. I actually had a scrub tech who I always said in the OR, I've had two great loves in my life, two great scrub techs that just knew everything, was exactly what I wanted. And they used to always ask to take the NG tube out, and I made them stop, because then I didn't do it, and they were always doing it. And then when I got somebody new, it wasn't on my list of things to do, and if I knew I was going to be with them every day, that would be fine, but I asked them to stop because otherwise I would forget when they weren't in the room. And then having a team, you know, I think when I thought about what does an OR, consistent OR team mean to me, I thought there was basically three kinds of operations that we're looking to do. And one is just to do a safe operation. I mean, when I'm in doing a gastric bypass or a sleeve, the bottom line is I want to do a safe operation. The patient just does well and has a good outcome. And then there's that, you get into that next step with a better team where you can do a little more efficient operation that goes in the right order of steps. There's really no little interruption. All the stapler loads are in the right order. The equipment is all done. Everything is in the room and ready to go, and the tech is pretty much familiar with it. But then when you get really good, and these are those two techs that I've probably had in my career that I don't really have right now, is we did it really proficient. I mean, everything, I know you never had to ask for anything. They knew every step of the operation. They recognized when there were changes. If I have 3 staple loads that I usually use to make the stomach, and on that third load I didn't get quite across, she already knows that I didn't divide the stomach and I need another load for that, and is asking for it before I even have had a chance to realize as well that I need to ask for that extra load that I just used, the third one. When you have that, that's great. And I think that's what leads to true crew resource management, that everybody really knows, because also they know me too. And because they work with me every case, they recognize when there's something different or off, but feel comfortable saying it because we work together every day, and know that I would appreciate that they open their mouth and not say that. And then the room gets a little bit more maybe relaxed and happy, and no one's stressed out to be there. They're not worried that I'm going to yell. I'm not worried that they're going to give me something wrong. And it's finally a nice atmosphere. And I think this just comes with familiarity and repetition, to be honest. We talk about crew resource management. I always like this because it shows these ultra-safe systems like nuclear power plants and railroads and aircraft carriers. And then it shows the really dangerous systems like bungee jumping and extreme mountain climbing and motorcycle racing, and hospitals falling in that really dangerous system, whatever. And so I don't know, I like these slides that our chief quality officer uses to talk about the crew resource management and how important that is. And what I tried to do then is look at what data is out there to support me in these consistent OR teams, even though I think all of us probably who do surgery believe that it's important to have the same people in the room for all the things, the reasons why I said. But this was an interesting study that I found. Surgical teams, role perspectives and role dynamics in the OR. And basically this was interviewing a bunch of different people and people observing in the operating room as well. Surgeons, circulating nurses, anesthesiologists, surgical techs, and then what the importance of leadership and team member competencies and an enacted environment that encourages feelings of competence and cooperation. Interestingly, what they found is that the climate in the room, the work climate, begins when the room is being set up, before the cases even starts. And the person that was most important for how the room dynamics early on and whether it was going to be good was the circulating nurse. She was the real leader in that room and setting it up. But then as the operation went on, depending on how the surgeon was behaving and his ability to relate to others, which makes me rethink my Monday mornings, really is what decides, what that will change the room, basically. It really has the most influence after that time to what amount of teamwork, team satisfaction, and team performance in there. So it starts with the nurse, and it ends up with the surgeon at the end. Here's another one that I think is important because we're one of those institutions, like this institution, which really does have a very rigid handoff type of system that has to be done a certain way. They actually even ask the surgeon's permission, they're supposed to at least, for handoffs and changes and things like that. And this was actually watching handoffs and turnovers. And they not only interviewed the surgeons and all the staff about the turnovers, but they also had somebody who sat in the corner with a clipboard and watched the turnovers. And what they found is that surgeons reported that handoffs decreased teamwork, increased work, increased stress, and were not optimal times in 31 to 45% of the cases and could be a lot better. And the independent observer actually found the same thing. However, the nursing staff that did the handoffs and scrub techs whenever had almost a zero, that 0% of the time it was a problem, that it was 100% seamless, never interrupted the case, never changed anything. And the difference were really very significant. And what this study said is that it demonstrated a lack of shared situation awareness, which is interesting because no matter even the same thing going on in the room, the surgeons and staff have a completely different perspective of what's happening in the OR. And again, when I'm trying to promote teams and stuff, I think that will help with this. No data to support that, but that's what I believe will happen. An increased stress in work, the surgeons need additional support from their team members, and if team members have no perception of the issues created by handoffs, et cetera, they will not act to lend the support that is needed. And I think that goes back to my previous slide about that proficiency and efficiency of the operation. If they don't even perceive there's a problem or something wrong, they won't be there to really help you. This is probably the most quoted article of all the research that I've done to figure out, is it good to have an OR team? So bariatric surgery with operating room teams that stayed fixed during the day, a multi-center study analyzing the effects on patient outcomes, teamwork, and safety climate, and procedure duration. So this was a study where they compared people who had a team that was fixed throughout the day, so the same team all the time for the entire operation versus handoffs and changes and teams changing in the afternoon and shift changes, et cetera. And they were 4 outcomes that they were really looking at. And of the 4 outcomes that they found out, just to summarize, there was no difference in patient outcomes. So I still think that this goes to my previous slide again, that they were able to do safe operations. The outcomes really weren't changed, or that didn't change at all. They found that the teamwork and safety climate improved significantly, and the procedures were performed significantly faster. As a surgeon, 3 to 11 minutes doesn't blow me away, but that was statistically significant. And the effect on the peripheral time, turnovers and things like that, were also not significant, although there was a little bit of a difference. Additional change was as the day went on, the more operations you did with the same team, the same operations, it just got better and better as the day went on. So their conclusion here was that working with fixed teams in bariatric surgery reduced procedure durations and improved teamwork and safety climate without adverse effects on patient outcomes. And the last study I'll talk about was actually presented at SAGE's, this is a poster, I think, that I have, that does a dedicated surgical team really make the bariatric surgery suite more efficient. And while there's a lot of, I had a lot of issues with this study, but it looked at 2 different hospitals that the same surgeon and fellow worked at and did the operations exactly the same way. One was a really large tertiary care institution that didn't have a dedicated OR team, and one was a much smaller, more community-based hospital with a dedicated surgical team that used every single time. And the nurses were always there, did all the nurses and scrub techs did every bariatric case with them whenever that they were there. And they were all bands, bypasses, and sleeves, and again, the same help with that person. So 150 at one, 59 at one, 52 at the other. There was no difference in patient demographics, et cetera. IRT is in-room time, was less with the consistent teams, but trended towards it, wasn't statistically significant. And then by procedure, there was really no difference. Operative time didn't differ, but what did differ is costs. They were definitely lower in the community hospital, and not only room costs, but also operation and procedure costs as well, and that there was some, less setup time when you had consistent teams as well. So their conclusion was that bariatric cases can be done in a more time-efficient and cost-efficient manner with a dedicated OR team. I would bet you that every community hospital does better than these large academic institutions. The costs will probably, for every operation that you do, would probably be the same. But since this paper, supported my claims that I really want to OR team, I thought it was important to present this paper as well. But anyway. Conclusions really, bariatric surgery is complex. None of the data really was all that compelling, but consistent and dedicated OR teams, they might lead to an improved work environment and increased surgeon and staff job satisfaction as everyone gets along much better. Consistent and dedicated OR teams may contribute to OR efficiency, improve patient safety, and decrease costs in some of the studies that I've presented. And with that, I'll ask any questions. I gotta throw up the OSU teamwork slide and champions and